of Cardiology. Dr. HART graduated from Middlebury College with a bachelor's degree in biology, and then went to the University of Vermont, where he received his medical degree. He then went to the West Coast for residency at the Lucille Packard Children's Hospital at Stanford, and then kind of came back partway to Michigan, where he did his pediatric cardiology fellowship at the University of Michigan. Dr. HART has been with us now for almost 2 years, and he has research interests in pediatric cardiology, particularly in prenatal diagnosis and management of congenital heart disease, which he's going to talk to us about today. I think he's already established a reputation as an outstanding teacher with both medical students and residents. And so look forward to your talk, Dr. HART. Thanks for—
Great. Thank you, Dr. Ottolini, and thanks for the invitation to speak today. Good morning, everybody. This is one of my first Zoom presentation, so someone please yell at me if the slides aren't appearing as they should. So today I wanted to introduce you to the field of fetal cardiology and looking at prenatal diagnosis and management of congenital heart disease. The CME code is here, and I think someone will put that in the chat box, and I'll put that at the end of the talk as well. I have no disclosures or conflicts of interest. So while this is a fairly large topic, I wanted to break it up into first talking about a brief history of fetal echocardiography, kind of where we've came from, and then transitioning more to the clinical side of fetal cardiology, including indications for referral to our office, kind of going through an outpatient visit, looking at a subset of congenital cardiology that may require prenatal intervention, whether it's medical or procedural, and then shifting gears to look more at research into the impact of prenatal diagnosis of congenital heart disease and its effect on postnatal outcomes. And then lastly, reviewing where we stand as far as how good we are at prenatal diagnosis and how we might improve that. So first, I find medical history fascinating, so I wanted to just touch briefly on the history of echocardiography. So this is Dr. Edler and Dr. Hertz in Sweden at their symposium in 1977, demonstrating this beautiful picture of one of the first transthoracic echocardiograms performed. So this is actually one of the first tracings that was published in the 1950s, and you might say that this looks nothing like a heart, and I'd agree with you. But this is something called M-mode echocardiography. So it's not producing a two-dimensional image, but instead looking at depth over time. So to kind of understand that, here is a slide I stole from a former mentor of mine at Michigan, kind of demonstrating M-mode echo. So there is a transducer, or the thing that you hold in your hand has a crystal that vibrates and it sends out ultrasonic waves. And those waves pass through the chest wall and then bounce off, or creating an echo off of certain structures like heart walls, heart valves. And depending on the time it takes to go back and be received by that transducer, it will create an image. So again, these images that I'm going to show are looking at distance from the probe. So from the probe through the chest wall to the heart over time. So a more modern picture of that is here. So you have the two-dimensional picture at the top of the screen, and then the M mode again. So this is time on the x-axis and depth on the y-axis, and you can see these blips are representative of the heartbeat. So in this case, the ventricle contracting. So this was a big advance in the initial imaging of really transthoracic echo, and later was applied to fetal. Obviously, advances in echo preceded the use of ultrasound on a fetus, and this was the first echo of an actual pulmonary valve and subsequent diagnosis of transposition of the great arteries in the early 70s. This is from a manuscript published in 73, and it's impressive that they use this, seemingly by current standards, rudimentary technology to diagnose pretty complex heart disease. So based on open and closure of the semilunar valves, the aortic valve and the pulmonary valve, based on this image, surprisingly, they were able to say that this one valve closes earlier, so therefore the vessels are transposed, and therefore the patient probably has transposition of the great artery. So certainly not how we would diagnose critical heart disease today, but that was kind of an early application of M-mode in the congenital world. The first time this was used in fetal cardiology was really in China, out of the Wuhan Medical College in the mid-60s. Dr. Wang published the first series of fetal echo tracings, again, M-mode. So this is an old manuscript, so the quality of the image is not quite as good. But similarly, similar to the prior picture I showed, these little blips are representative of heartbeats. Not until 8 years later or so in the US in the early 70s was this technology demonstrated in the US by Dr. Winsberg. So this is the first published fetal echo on a 39-week-old normal fetus. And again, so this is the camera is kind of up here at the top of the picture looking down. So here's the right ventricular wall contracting, these blips. Here's the right ventricular cavity where the blood is, which is black, ventricular septum, and then the left ventricle. Several years later, two-dimensional echocardiography was demonstrated, and there were several studies published in kind of the late 70s, early 80s, actually looking at fetuses and then correlating those findings with postnatal autopsy, because back in that era, it was unusual we didn't have the surgical approach to fix these heart diseases, so oftentimes babies with critical disease wouldn't make it beyond the neonatal period. So they were able to kind of examine what they saw on two-dimensional echo with, again, relatively crude imaging, and then compare it and improve their diagnosis by looking at the postnatal fetal autopsy. Next steps in innovation really involved the application of Doppler with ultrasound. In the mid-80s, Nanda and colleagues out of the University of Alabama were able to assess a number of pregnant mothers using Doppler ultrasonography. And what that gives us over two-dimensional imaging is the ability to measure direction and velocity of blood flow. So again, while the picture isn't particularly pretty, this image here is the two-dimensional picture in this line going through the heart. So this is the heart. It's passing over the tricuspid valve. And what this Doppler picture shows is tricuspid valve regurgitation. So the invention of Doppler and being able to measure direction and velocity of flow was a big advancement, really in the mid-1980s. And then again, around that era, kind of mid-80s, was the invention of color Doppler. So the ability, like many of you have seen us read echoes in the hospital, see flashes of red and blue, and that's color Doppler. So that also gives us a sense of directionality of blood flow. So here's a cartoon picture of a heart, a 4-chamber view, and this color Doppler picture corresponds to that. And these two red areas here represent inflow across those AV valves. So that was in the mid-80s. So we've had, over the past 50 years, had significant evolution from the earlier machines here in the 1950s and 60s to the 70s and 80s. And now this is the most common machine you see around the hospital in our clinic that's giving us much more informative imaging that makes diagnosis a little bit easier. So I wanted to go through just a couple videos of kind of what we see on fetal echocardiogram to give you a sense of what it looks like. So the orientation is challenging in fetal echo because you have the mother, but then the baby is constantly moving, which makes it fun, but also particularly challenging for imaging these tiny hearts. The scale along here is representative of a centimeter, so between these two dots. So you can see what we're looking at, depending on the gestational age of the fetus, is really 2 to 3 centimeters in size, and we're looking through potentially a lot of maternal tissue through a lot of fluid. So it's remarkable what we can see despite the structure being so small. So this is a normal heart. The maternal wall is here. Let's stop playing. You can see this is the chest wall of the fetus. Here is the left ventricle, right atrium, and left atrium. Just to introduce some pathology, again, a similar orientation with the chest wall, the fetus being here. Here's the apex of the heart. Here's the right ventricle, left ventricle, and the ventricular septum here. And you can see RV, LV, there's this large defect in this ventricular septum representative of a large muscular VSD. A more severe and more obvious diagnosis that's seen here is the orientation in this picture, or this video on the left, is slightly different with the apex over towards the right of the screen here. This is a large ventricle, atrium, and a smaller ventricle. Similarly on this picture, showing the same heart in a different orientation. And this is indeed representative of hypoplastic left heart syndrome, where you can see this little nub in here is the hypoplastic left ventricle and a large normally formed right ventricle. As you can imagine, this is one of the types of heart disease that's more frequently prenatally diagnosed because it's so obviously abnormal from a typical 4-chamber view. And lastly, just for an example, similar orientation to the first couple pictures or videos, with the apex of the heart here, left ventricle, right ventricle, left atrium, right atrium. And instead of having two separate valves, you can see this one common large valve opening over a large VSD here. And this is a video of a complete atrioventricular canal or atrioventricular septal defect. So those are just a few examples of types of heart disease we'll see here in clinic. And although we are able to diagnose the majority of heart disease, there are certain limitations to fetal echo that I wanted to touch on. Certainly atrial septal defects are very difficult to predict on a fetal echocardiogram, one, because there's already a very large pre-existing atrial defect called a patent foramen ovale. Small VSDs are difficult to evaluate given on postnatal echocardiogram, we're really relying on a pressure difference between the right and left ventricle. And the a fetus really has equalization of right and left pressures, and therefore small VSDs are difficult to assess. Similarly, partial anomalous venous return and mild valvular abnormalities are difficult to see. Coarctation of the aorta is the bane of most fetal cardiologists. It's very difficult to predict, and oftentimes if there's any suspicion of it, we'll hedge and usually get a postnatal echocardiogram to confirm or refute our concerns. And then PDA, as you can imagine, most fetuses have a large PDA, and you can't predict whether that will remain patent after birth. So that's something we cannot really diagnose in utero. So I wanted to switch more towards the clinical side of fetal cardiology, including kind of indications for referral. So we see patients for a number of different reasons, and this is a list of some of the more common reasons for referral to our clinic. The first being congenital heart disease in the first degree relative. So we know that fetuses that have either a mother or father affected with congenital heart disease have an increased risk. So the general risk overall is about 2 to 5% chance of recurrence in the fetus, but that is really variable depending on the type of heart disease in the relative. So for example, something like hypoplastic left heart or a left-sided obstructive lesion like aortic stenosis can carry a recurrence risk of up to really close to 20%. Suspicion for congenital heart disease or arrhythmia on OB screening is another reason. Uncontrolled maternal pregestational diabetes, we know, causes an increased risk of disease, although kind of normally controlled, either gestational or pregestational diabetes has really no significant increased risk of heart disease in the fetus. Maternal autoimmune disease, including lupus with autoantibodies, puts fetuses at risk of heart disease, particularly complete heart block, which we'll talk about in a minute. And maternal medication exposures, extracardiac malformations such as phalloceal or diaphragmatic hernia, or syndromes like trisomy 21 actually have a significant association with congenital heart disease. And then lastly, monochorionic or monozygotic twins, so identical twins with a shared placenta, we know have an increased risk, and particularly twin-to-twin transfusion syndrome. When we see a mother, a pregnant mother in our clinic, we'll gather some maternal and family history. And then the majority of our visit is really devoted to the fetal echocardiogram and then appropriate counseling surrounding what is seen on that. We'll, again, it's really largely dependent on the type of disease, but we'll discuss morbidity and mortality for that specific lesion and the anticipated lifespan. And that's really, what first comes to mind typically for a pregnant mother. We'll discuss neurodevelopmental outcomes, which are really more applicable, and there's growing research into neurodevelopmental outcomes in single ventricle disease or really any neonatal, any lesion that requires neonatal surgery. We'll present all options, including termination and the legal ramifications surrounding that, as well as the option of palliative or comfort care following delivery in those with real critical heart disease. Delivery planning is a big part of our counseling, including whether the baby would benefit from a vaginal delivery versus a C-section, where it would be best for the mother to deliver, whether that would be at a tertiary care facility or whether it's okay to deliver at a smaller community hospital. And then discussion about what we expect the baby to need as far as postnatal care in terms of whether they would be okay to stay with the mother or whether they would need admission to the NICU for further evaluation and intervention. And as you can imagine, some of these visits, mothers will be referred for a certain reason and really have no significant suspicion of major disease, and it would be sometimes quite a shock to the parents if we diagnose more critical disease. So we provide support and connect with social work as appropriate. And then, as you can imagine, anyone given a diagnosis that is so foreign to them with such a huge impact on their baby, oftentimes will turn to Google to see to learn more about the disease. So we really try to get in front of that and provide some reputable resources for them to reference. So next we'll turn to fetal cardiac intervention. So we'll review kind of a subset of patients with prenatal detected cardiac disease that would potentially benefit from either medical intervention, such as those with arrhythmia, or procedural intervention, in a subset of patients with heart disease. First, we'll discuss fetal arrhythmias, so tachycardias and bradycardias, including SVT, atrial flutter, and then we'll focus on complete heart block, although there are other forms of bradycardia. So when we see, this is one of the more common types of fetal heart disease that we see that requires intervention, fetal reentrant SVT. So about 90% of fetal tachycardias are this type of SVT. So it's kind of the classic reentrant SVT you think about in a newborn or school age person. Typically heart rates are in the 220s to 260s, but sometimes do reach into the 300 range. The majority of fetuses will have structurally normal hearts. And rates generally, in the mid 200 range will often progress to high drops. But that progression is really dependent more on the duration and consistency of the arrhythmia versus the absolute rate. So we may see some patients with heart rates up to the 300s, but it's happening intermittently, and therefore the heart generally tolerates that well if it's happening, less than 50% of the time. Fetal atrial flutter is much less common than reentrant SVT. It shockingly has atrial rates in the 400 to 500 range, which is hard to even imagine. But because the AV node only can conduct so fast, we see ventricular rates usually half or a third of what the atrial rate is. So oftentimes in the 200, the mid 200 range. And here's a picture of that. Again, going back to our ancient echo mode of M mode that we still use very frequently. So I've kind of, again, this is depth. So we're looking, this picture corresponds to this M mode tracing. So we're looking through the wall of the atrium, through the crux of the heart, and then through the left ventricle. And I've pointed out with these arrows, you can see the atrial rate ticking along here at a rate of around 400. And you can see the ventricular rate here on the bottom line is half of that. So the red arrows point out the ventricular contractions here. So again, so we call this 2-to-1 conduction with every one ventricular rate for every 2 atrial beats. Here's a video of that, actually, of a patient we've taken care of recently. And if you look closely, it's a little bit hard to appreciate on this PowerPoint, but the atrial wall is basically vibrating at a pretty high frequency, and you can see there's the ventricular wall that's going slightly slower. So this is 2-to-1 conduction in a fetus with atrial flutter. Moving on to treatment for fetal SVT. Typically, treatment is offered for fetuses less than 37 weeks and with heart rates that are over 220 beats per minute, that it's occurring greater than 50% of the time, or the presence of high drops. The standard of care is transplacental therapy with either digoxin, flecainide, or sotalol, and the goal is to really achieve both rate and rhythm control. A lit review from 2009 looked at efficacy of these agents, and usually our first line agent digoxin, and you can see that it's around 50% effective, with flecainide and sotalol being slightly more effective, but they have a little bit higher risk profile for both the fetus and the mother for being pro-arrhythmic. So generally, we'll proceed with digoxin as a first line agent. Fetal heart block is quite a devastating diagnosis. Like I said, it's oftentimes the result of maternal autoantibodies, such as anti-Rho and anti-LAW. We'll see heart rates typically in the 50 to 80 range in third degree block. And 50% will have structurally abnormal hearts, while the others will have structurally normal hearts. Typically, this will kind of manifest in the 18 to 28 week period of gestation. And the thought is that the autoantibodies are really inducing a fetal myocarditis that's causing destruction of conduction fibers. We know that fetal block is, the risk for it is around 2 to 3% in a mother with autoantibodies, and those risks significantly increase if the mother's had a previously affected child. Management of fetal heart block is quite limited at this point. We do have frequent monitoring of patients that are at high risk in the at-risk time between 18 and 28 weeks gestation. And we're really monitoring for any progression of the PR interval. So looking for progression to second degree block or presence of third degree block. There's very limited evidence to support use of maternal steroids, although we still do. And a meta-analysis from 2019 looked at over 1,000 cases, and maternal use of glucocorticoids really did not improve fetal or neonatal survival. This is a figure from that meta-analysis, and you can see that on the right of the figure is the odds ratio, where the left side favors use of steroids, the left side favors no intervention. And you can see there's really no benefit to steroids for fetal death. Looking at a downgrade of fetal heart block, so if a fetus has third degree heart block and steroids are given, does that regress to second degree heart block? And again, favoring steroids is here on the left side, favoring non-intervention is on the left side, and strangely, you see more spontaneous regression from third degree to second degree with no intervention. So certainly steroids is not helping in that situation. And similarly for neonatal death, again, no benefit to using steroids in the mother. Here's a video of a fetus with fetal heart block. So you can see, so here is the right ventricle, here's the left ventricle. The left ventricle is thickened and probably has fibrosis, and you can see a large pericardial effusion. And you'll note the rate is quite low, probably around 50, which is very abnormal. So a devastating diagnosis that's has a very high incidence of mortality in the postnatal period. So next I'll move on to procedural cardiac intervention on a subset of patients. This is still, I don't want to say experimental, but it's really only offered at certain centers and has variable success rates. We certainly don't offer this at Maine Medical Center, and Boston Children's Hospital is probably the leader in this work. So I'll talk about a few subsets of heart disease here that are potential candidates. The first being hypoplastic left heart syndrome. So just to review for those unfamiliar with the disease, hypoplastic left heart involves often atresia or severe hypoplasia of the mitral valve here, a very small left ventricle and small aortic valve and small ascending aorta. So basically hypoplasia of the whole left side of the heart. This is a cartoon of the procedure itself. So in patients that are deemed to be good candidates, but there's an extensive kind of selection criteria to see which hearts may respond best to this procedure, which I'm not going to go through today. But a needle is inserted through the mother's abdomen, through the uterus, through the chest wall of the fetus, through the left ventricular free wall, and out of that needle, a wire is advanced across the aorta. And then a balloon, coronary balloon, is actually inflated to around 3 millimeters, which tears that tissue and allows more antegrade flow, theoretically, from the left ventricle out that small hypoplastic aorta. The outcomes from this are encouraging from very highly selective cases, and there is certainly debate on whether the patients that undergo this procedure and have a successful repair, whether that intervention actually led to that successful repair, or whether the heart was going to continue to mature and allow for a two ventricle repair regardless of the procedure. But Boston has the largest cohort of 136 fetuses with an overall technical success rate at the time of 82%, meaning that they were able to open up that aortic valve, and a fetal demise rate of around 10%. The technical success rate is, I would argue, is less important than the postnatal kind of outcomes. So they were able to achieve a 2 ventricle repair compared to a single ventricle palliation in 41% of the patients, which is and closer to 60% on more recent cases over the past several years. But longer term outcomes have really not been well established. A second subset of heart disease that has potential benefit from fetal intervention is pulmonary atresia with intact ventricular septum. You can think of this almost as the opposite side of the heart as far as the intervention that I just discussed. So pulmonary atresia with intact ventricular septum has a large spectrum of disease where some fetuses and babies will have a normal size right ventricle, others will have a very small right ventricle. But the idea is to basically open up the pulmonary valve prenatally to allow this right ventricle to develop more normally. This is a much less common disease as far as prenatal intervention. And some of the largest cohorts are really only about 16 fetuses with marginal success. Here's a video of a fetus with pulmonary atresia with intact ventricular septum. Here on the right is the two-dimensional image. On the left, you can see this is the left ventricle, right ventricle, and this color Doppler overlay demonstrates this big blue jet, which is tricuspid valve regurgitation into this dilated right atrium. Because when the right heart squeezes, there's nowhere for the blood to go in that right ventricle except for back across the tricuspid valve into the atrium. The last subset of heart disease that is potentially amenable to fetal intervention is hypoplastic left heart syndrome with intact atrial septum. The real rationale for this type of intervention is different from the prior two in that we're not trying to prevent progression of disease, but really trying to prevent postnatal death and severe lung disease. So an intact atrial septum occurs in about 6% of patients with a hyperplastic left heart. And why that matters is if you think about it, so blood is coming back from the lungs through these 4 pulmonary veins here, and it has to go somewhere from the left atrium. So if there's no outlet through the mitral valve, it has to go back across this hole between the top chambers. So therefore, if this closes up, this causes severe left atrial hypertension, causing permanent lung damage and postnatally with decreased cardiac output. The approach is similar to the previously described procedures, with a needle going through the heart across the atrial septum and tearing a hole in the atrial septum. The initial success of the procedure is in the 60 to 70% range, but unfortunately, over the remainder of the gestation, these holes typically close up, and therefore the benefit is lost. And again, at least the Boston Children's experiences really showed no benefit in mortality between those that received it and did not get the intervention. So you may ask, why are we doing this if there's not a lot of benefit? And the reason is we know that patients with this subset of hypoplastic left heart have really abysmal outcomes. This is a figure from a Pediatric Heart Network study from Fetal and colleagues, looking at, this is a Kaplan-Meier curve showing survival over time of a standard hypoplast here. So you can see that's approximately 60% 4-year survival. And here is someone with that type of heart disease with an intact atrial septum. So you can see immediately survival drops off immediately after birth to around 15 to 20%. So we know that if we don't do anything, these babies will likely die. So some centers like Boston are really trying to push the envelope and push this, improve the technical aspects and hopefully eventually improve postnatal outcomes. So next, I want to switch over from really discussing kind of the clinical care and intervention to looking into research of, is all this work that we're doing as far as prenatal diagnosis, does it really impact postnatal outcomes? So initial studies were less clear on this. This is a study from the late 1990s looking at hypoplastic left heart syndrome in transposition of the great arteries, comparing those that were diagnosed prenatally and postnatally. And there really was no significant difference in pre-op mortality or post-op mortality in those diagnosed either prenatally or postnatally. Highlighted in the red box, you can see ventilated time, hospital stay, and operative mortality. And there's, again, no significant difference between the two groups. This was a relatively small data with small numbers. And since similar studies have been conducted with demonstrating different results. So this is the first study to show improvement in perinatal outcomes out of Stanford in the early 2000s, looking at 88 patients with around 40% diagnosed prenatally and 60% diagnosed postnatally. And among those 52 patients that underwent surgery, those diagnosed prenatally had significant less morbidity preoperatively and also better postoperative outcomes in the group that was diagnosed as a fetus. So you can see here the white bars are fetal diagnosis, the gray bars are postnatal diagnosis, and you can see all of these are metrics that would represent preoperative morbidity, including tricuspid regurgitation, ventricular dysfunction, need for inotropic support, and acidosis. So this was encouraging as far as, we're doing some good. Subsequent studies, this is another study from around the same era out of France, looking at a larger cohort of patients of 250 postnatal diagnoses and around 70 prenatal diagnosis, and specifically transposition of the great arteries. And here you can see a significant improvement in both preoperative and postoperative metrics. So mechanical ventilation, acidosis, significantly improved in the prenatal diagnosis group. Preoperative mortality, they had 0 versus 15 in the postnatal group. And then postoperative mortality as well was much better in the prenatal diagnosed group. More recent studies over the past 5 years have shown similar benefits to prenatal diagnosis of critical heart disease and for preoperative survival. So this is a large meta-analysis looking at 8 studies, including a large cohort of patients for our field, including 300 prenatal diagnoses and over 1,000 postnatal diagnoses of critical heart disease. So this included hypoplastic left heart, transposition of the great arteries, and then other single ventricle diseases. In their meta-analysis, they did exclude certain babies that were deemed high risk, such as those with prematurity, other major congenital malformations, then acquired things like meconium aspiration, as we know those would generally affect any baby with heart disease. And then they looked at really preoperative mortality in those prenatally versus postnatally diagnosed, and you can see that only less than 1% died preoperatively in the prenatal diagnosis group, and 3% died in the postnatal diagnosis group. And the authors actually proposed that these are the benefit of prenatal diagnosis is actually underestimated, because many studies actually excluded those diagnosed on postnatal autopsy and also those transferred from outside centers. So you would think that, again, prenatal diagnosis would have, potentially prevented some of those mortality as well. This is a landmark study out of Texas Children's Hospital and the Pediatric Heart Network, looking at hypoplastic left heart syndrome and the effect of distance, where they're delivered and distance from a congenital heart center. So going through these figures, so the neonatal mortality is here on the y-axis, birth era in the x-axis, and you can see those represented by the dark black are those delivered greater than 90 minutes from a surgical center. And you can see that compared to those that were born closer to a surgical center, had significantly increased mortality in both birth eras. The overall rate of mortality is slightly lower in more recent era, but overall the pattern remains. Separating out in postnatal and prenatal, you can again see the same pattern where those delivering further away again had increased mortality relative to those delivering closer. This is separating out kind of timing of death. So you notice that really there's really not a whole lot of change in mortality between those delivering far away or close to a surgical center in the operative period or preoperative period. But really the majority of the difference is in this pre-transport. So if you think about these patients as the ones that are delivering at a smaller community hospital, maybe receiving that postnatal diagnosis and having a prolonged period of time before they're transferred and cared for by a pediatric cardiologist. So while this doesn't explicitly address the benefits of prenatal diagnosis, it does show that babies delivering at a site further away have increased mortality, and therefore prenatal diagnosis would most likely convince many of those delivering far away to transfer their care and deliver at a major center, and therefore much of this kind of pre-transport death would likely be prevented. So we've kind of looked at morbidity, mortality, and it seems to be a clear benefit of prenatal diagnosis, but I wanted to touch on the impact of fetal diagnosis on brain health. As you may have remember from Dr. Miller's grand rounds last year, there's a ton of research going into neurocognitive development and outcomes in those with congenital heart disease. This group from UCSF posed the question of, could prenatal diagnosis really improve neurodevelopmental outcomes, at least in the neonatal period? So what they looked at here, they looked to compare prevalence of preoperative brain injury and also the trajectory of brain development in neonates with prenatal versus postnatal diagnosis. So babies here were scanned right after birth and then before discharge following their surgery. And among 153 patients, the most had transposition, and then the remainder had single ventricle physiology. And you can see here highlighted in the red box of all the patients, including both transposition and single ventricles, that there was a significantly decreased rate of preoperative brain injury in those diagnosed prenatally. We'll talk about why that might be in a second. From the same study out of UCSF, they not only looked at preoperative brain injury, but then looked at rate of brain growth during the neonatal period. So this, focusing on this figure on the left, here is a measure of brain growth on the y-axis and then gestational age on the x-axis. The yellow line is representative of those patients with prenatal diagnosis, and the blue line is postnatal diagnosis. And you can see that overall the growth trajectory is increased compared in those that were diagnosed prenatally. So the mechanism or the proposed thought of why this may be, and it's probably similar to those for why mortality is less in the prenatally diagnosed group, is many of these patients probably have a better hemodynamic state going into surgery. There's less significant acidosis prior to surgery, a decreased prolonged period of significant cyanosis compared to those born at a outside smaller community center and potentially living with saturations in the 50s for a prolonged period of time. So quicker and quicker starting of prostaglandin therapy. All of those factors are proposed reasons for why we see this difference in both brain growth and also preoperative brain injury. So it seems fairly well established that what we're doing here is doing some good as far as improving outcomes in patients after birth. So the next question is, how good are we actually diagnosing prenatal heart disease? And unfortunately, the answer is not great. So this is a figure from a Pediatric Heart Network study from 2015 by Quartermain and colleagues, looking at rate of prenatal diagnosis by year in those neonates. The white bars represents neonatal surgeries. The black bars represent infant surgeries. So we see that really the average was around 26% in 2006, and that has increased some over the years. In 2012 was around 42%, accounting for both infant and neonatal surgeries. But overall, less than half as of 2012 were really being diagnosed prenatally. And this data comes from the Society of Thoracic Surgery database, and a total of over 31,000 patients at 91 centers. Separating out the rates of prenatal diagnosis by specific heart lesion is even more informative. So if you look at those diagnosed, those heart diseases that look normal on a typical 4-chamber view obtained on prenatal screening in the obstetrics office, diagnosis is much lower. So patients that have tetralogy of Fallot, transposition, or truncus arteriosus, a typical 4-chamber view of the heart may look very normal. So therefore, you can see rates as low as 20 to 40%, versus heart disease that looks abnormal, such as hyperplastic left heart, on that 4-chamber view have higher rates of diagnosis. So it's really that outflow tract view, which is difficult to get, and those that require it are diagnosed less prenatally. This is from the same study, again, further separating out by lesion. So patients with total anomalous pulmonary venous return, or VSDs, are diagnosed much less frequently, in the realm of 10%, versus hypoplastic left heart is diagnosed much more commonly, given how obvious it is on that 4-chamber view, around 65 to 70%. And again, from that same study, they actually separated it out by region. So there is regional variability, but as you can see, overall prenatal detection rates are not great. So we're up here in the 32% range. But again, this is somewhat dated data from 2006 to 2012. So I'm hopeful that we're slightly better. in the current era. This is preliminary data that I pulled from our patients here at Maine Medical Center. So looking at children with congenital heart disease requiring intervention before 6 months, either born at Maine Medical Center or transferred to after birth. And over a 12-month period from 2019 to 2020, we had about 21 patients with critical heart disease and had a prenatal diagnosis of 62%. Well, that number seems quite high and it's encouraging, although again, this is preliminary data and I'm sure there are reasons for why we might not be accounting for those that were missed prenatally. So lastly, I wanted to touch on, we're not doing a great job diagnosing fetal heart disease. So how might we improve? And this has been a more recent area of investigation. And this is a study from last year that again, out of the Pediatric Heart Network that aimed to identify barriers to successful screening for congenital heart disease. We know that the sensitivity of obstetric ultrasound can be as high as 85% when we look at both the 4-chamber and outflow tract views. But despite 90% of women receiving an ultrasound, our diagnostic rates remain quite low. So this study looked to focus on kind of more rural community centers, given that 75% of prenatal screening occurs in these non-tertiary care settings. What they did is form focus groups at 4 regions across the country and interviewed radiologists, obstetricians, and other providers performing or interpreting fetal ultrasounds. And some themes emerged during the interviews. They were really to identify kind of 3 main themes. 1, individual level barriers, including comfort or confidence with cardiac imaging or training and experience in cardiac imaging. External barriers, such as lack of feedback from subspecialists, including pediatric cardiologists or MFM. And systemic level barriers, including varying volumes, access to expertise, and lack of formal standard quality control. So I pulled a couple of quotes that I just thought were informative, and they pulled these as representative quotes from their many interviews. So in terms of ability or self-confidence in imaging, one said, "To be perfectly honest, I never feel horribly comfortable with heart screening." Others, in regard to training, said, "All you really do in residency is try biometry and assess how big the baby is." And then in terms of feedback, one said, "I would also mention that getting the feedback from my referrals would increase my knowledge. Hearing back was very valuable, so that communication between us and those who we refer to is very important." Looking at organizational barriers, one said, "With initial prenatal detection, ultrasound is done in thousands of different offices by physicians doing low volume and low risk," just suggesting that some of the smaller centers are just not used to seeing or focusing on critical heart disease. And then in terms of policy quality control, one mentioned, "We are taking on certification for nuchal cord translucency and cervical length, but yet for cardiac images, a basic 4-chamber and outflow tract view, there is practically no accreditation system." So from these 4 focus groups, they were able to create a national survey composed of multiple questions, assessing various self-assessment of knowledge, perceived usefulness of fetal echo, physician confidences in their ability to interpret cardiac imaging. And then part 2 of the survey was really providing video clips of 20 different video clips of hearts, either normal or abnormal, and showing both a 4-chamber and outflow tract view. And I like that they included kind of real life imaging, that might be affected by maternal obesity or abnormal fetal positioning. And as you can see here, I'll blow up in these rates here in non-tertiary care settings. The rate of accurate diagnosis of the clips provided was around 60 to 70%. Lower for outflow tract views and higher for normal hearts. So from both the survey and the evaluation of the provided standard images, they were able to propose potential interventions to improve prenatal diagnosis in this more community setting. One being expanding interventions to include physicians who interpret images, as historically really a focus has been on sonographers. So a sonographer may get a great image, but maybe the physician doesn't have the training to interpret them. Next would be establishing guidelines for training and maintenance in OB ultrasound interpretation, focus training on cardiac portion of the ultrasound, and then certification for cardiac screening, as is currently required for nuchal translucency and cervical length evaluation. And then lastly, telemedicine or overreading of studies in smaller community settings may help pick up more heart disease. And lastly, just to show how screening programs can be effective, this is out of the Netherlands, a study in 2016 where a national screening protocol was introduced in 2007. And they were able to increase their prenatal detection of heart disease by 24%, with an average of all heart disease around 60%, which is remarkable. And then looking specifically at these single ventricle diseases like hypoplastic left heart syndrome, they reported a prenatal detection rate of 95%, which is impressive, almost hard to believe. So we know screening programs can work. So in summary, fetal echocardiography can diagnose a majority of significant congenital heart disease, but does have limitations as discussed previously. There are a multitude of benefits to prenatal diagnosis, including parental counseling, delivery planning, a subset for therapeutic intervention, and then clear benefit to perinatal outcomes in those receiving a prenatal diagnosis. Unfortunately, the prenatal detection rate remains quite low, but there are ongoing efforts to identify barriers and improve prenatal diagnosis in the US and across the world. Lastly, I just wanted to throw in this side for practical take-home points for the audience. I wanted to highlight that when we see patients, each of our fetal echo clinic notes is in EPIC and should contain recommendations for postnatal care. So these are helpful to reference if you're wondering, what a baby is expected to look like when they're born. So there should be information on where a baby should go, necessity of postnatal studies, potential necessity of interventions like prostaglandins or umbilical lines, and then expected postnatal oxygen saturations, because that's always, comes up. Prenatal evaluation, we can be wrong. So your clinical assessment, trumps all. So always assess the patient and practice palpating those femoral pulses. And then lastly, always feel free to reach out to us in pediatric cardiology, whether there's prenatal or postnatal concerns or questions, potentially whether, if you're an OB, whether you're maybe a relative has some form of a disease and does my patient need a fetal echocardiogram, or if you're a pediatrician and have a new patient in the office, and are unclear on whether they would need a postnatal cardiology evaluation, please reach out to us. So with that, I'll end. Thank you very much. And again, there's the CME code. And I'm happy to take questions.
I think one of the questions from Melissa Keyport, Mike, thanks for that that wonderful, very informative grand rounds information that we all never knew about fetal, what we can do to help the fetus either prenatally or after birth. So from Melissa Keyport, can you remind us what percentage of congenital heart disease is detected prenatally? I had a recent newborn with interrupted aortic arch that wasn't detected prenatally.
Yeah, good question. So currently we're around the the 50% mark as far as prenatal detection. Something like interrupted aortic arch is probably one of the more common things to be missed. Again, because that oftentimes that 4-chamber view, which is seen on screening ultrasounds, is often normal. So again, that's really where it becomes imperative to see that, to rely on that postnatal assessment. So one, the congenital heart disease screening that we do on all babies now, assessing pre and postnatal SATs, would pick up something like a interrupted arch, and potentially, again, feeling for those femoral pulses is really critical for assessing for coarctation. So yeah, unfortunately, that's something that, is still commonly missed. We have one recently in the hospital now, actually. And yeah, but good question.
Any other questions? All right, well, thanks very much, Dr. Hart, for a very interesting and informative talk.
Thanks so much. Thanks everybody for joining.